Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Physicians and Pre-Exposure Prophylaxis, better known as PrEP. Today's program is part of the Start Talking Alabama social media campaign that was created to reach young gay men of color in Alabama. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in this program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. Nurse practitioner pharmacology credit has also been approved. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on June 30, 2019, and 2 years for social workers, expiring on June 30, 2020. I'm Warren O'Mara Dates, Senior Linkage Specialist for the Northeastern District at the Alabama Department of Public Health and Senior Producer of the Start Talking Alabama campaign. Joining me today we have Dr. Marguerite Barbara Owens and Joannica Ellerson, J, with Medical Advocacy and Outreach, and Jonathan Brown, co-host of the Start Talking Alabama campaign. Welcome everyone, and thank you all for being here. Let's get started with our conversation. Dr. Owens, tell us a little bit about who you are and why you chose the field of HIV medicine.
I'm originally from Washington, D.C. I've been here 30 years, so I guess I'm from Alabama now. I did private practice for 25 years. Okay. But even during my private practice, I supported MAO. And I think my heart goes back because my best friend in medical school died from HIV when it was first being recognized, and so she had PCP pneumonia and rapidly deteriorated and died. Okay. So it has always been close to my heart, and when I closed my practice, there was an opening and saw fit to call me, and I came.
Into the family.
Into the family.
Welcome. Jay, tell us a little bit about who you are and why you chose to practice medicine in the HIV field.
Well, I'm from Birmingham, Alabama. Me and my husband moved here due to military. But when I first came here, I was a nurse, and so I worked in the hospitals and in private practice. And after graduating from school, one of my friends told me about the opening. She was coming to apply for it as well. And in high school, I was always interested in HIV. When I actually did nursing school, when I did my bachelor's, I did a kind of a pre-op or a, what do you call it? A poster board on it towards the end of the semester, and it got me even more interested in it. And so when this came available and she told me that they were looking for providers, I thought that this would be something nice. And so I came and shadowed Dr. O, and I've enjoyed it. I love my patients. I enjoy taking care of them. And it's just something that I really have enjoyed and think that it's something that I enjoy doing.
And you had a good teacher in Dr. O. So Jonathan, tell us why and how you're affiliated with the Start Talking Alabama campaign.
Well, I am the co-host on the campaign. I'm originally from St. Louis, Missouri. I moved here back in 2013, back to Birmingham. And since, living in St. Louis and then also coming back to Birmingham, I've done volunteer work in the LGBT community. I chose to be a part of the campaign because of my passion and my drive for my community. And it's gratifying to each and every day wake up and do the work and know that I'm a being or a person that is implementing change in my community.
Wonderful, wonderful. So we're going to have a conversation today about PrEP, which is a hot button topic among public health officials and organizations around the country. And so we want to give our audience as much informed information as we can. Dr. O, tell us what you as a provider know about PrEP and how it works and how it's offered to individuals.
So PrEP is pre-exposure prophylaxis. You've already said that. There is only one medicine at this point that is approved for PrEP. The name of that medicine is Truvada. It's offered once a day. There are, in the future, lots of different medicines being in the pipeline, so to speak, for PrEP. But right now, we only recommend this one medicine. Truvada is a medicine we've had experience with because it's part of the treatment for a lot of people with HIV.
Mm-hmm.
But PrEP is in a unique position in that it will prevent HIV, and it's part of a whole program. Jay does very well in charge of our PrEP program.
Mm-hmm.
And so it's just not to give the medicine.
Mm-hmm.
We encourage the education, the frequent testing, the use of condoms, and to be aware of all the things that go with PrEP. So it's just, as I said, a part of a whole education process.
Okay.
I think the issue for me is PrEP has been around 6 years now, and we still haven't, you said it's a hot topic. I wish it were more of a hot topic for not only the Department of Health, but physicians and providers in general, as well as the public, because something came out recently that talked about of the people eligible to take HIV, take PrEP. There still is not a good uptake. Still not a lot of people. Still not the majority of the people that should be on it are still not on it, and they're not even being having the opportunity to discuss it with their providers. So I think there still is. It needs to be a hot topic because we need to know more about it and be more using it more.
Okay, and that's a good lead-in question for you, Jay. Tell me who would be a candidate for PrEP.
Pretty much anybody can be a candidate for PrEP.
Okay.
It was originally developed for what we consider our MSM population, our men that have sex with men. However, it's grown to so much more because just about, like I say, anybody that has sex can be a candidate for PrEP. Majority of my patients either have a partner that's HIV positive, so they take it to prevent their partner from transmitting it to them. We have some patients that what we consider sex workers that it works for. And then we also have some patients that just have multiple sexual partners that it works for. So PrEP pretty much can be, anybody can be at risk for HIV.
Okay.
And so therefore Truvada can be pretty much eligible for anybody. Now as far as whether you actually qualify to take it, it plays into other roles as far as your health, different things that you have going on, and that comes into play as well.
Okay, so having the conversation with your provider is what you two would recommend to become a candidate in the beginning. So Jonathan, we're going to bring you into the conversation because I have been made aware that you are a PrEP patient at this point in your life and your living. Tell us what that experience is like, what it was like for you getting started, kind of what were the thoughts behind your motivation to get started as a PrEP candidate, and then tell us what it's been like since you've been a person living, taking the pill.
Absolutely, absolutely. So part of the reason that I made the decision to be on PrEP or be prescribed a PrEP is because being a gay man, in being sexually active, there is a kind of dark cloud that carries over myself, and other people may experience it as well, but being scared to be sexually active, and then having that, even if you use a condom or use protection, it's always that daunting feeling that kind of weighs over you after being intimate with someone. So that was part of the reason I decided to be on PrEP, and I've been on it for 2 years now. Another reason is just doing the work, going out and speaking to people that are younger than me or having colleagues that are older than me. I felt the need to be on PrEP because how am I going to talk about practicing safe sex if I'm not taking the proper measures myself?
Okay, so you want to be a doer of the word that you speak every day.
Absolutely, absolutely.
Okay, Dr. Owens, as a practitioner with MAO, tell us about kind of how you introduce PrEP to an everyday client that you may have coming into the clinic.
So part of the history at the beginning is always going to be about how many partners, whether your partner's aware of your status, what your partner status is, where you might meet your partners, those kinds of questions come up. And so anyone who gives me a history, that would suggest that their partner may need to be on PrEP is. We always bring it up then. There's posters about it. Sometimes they bring it up before I even bring it up, which is a good thing. So that's the beginning. But we continue to have that conversation because every time they come in, those questions still are asked and discussed. And so we continue to have those kind of conversations.
Like HIV, we know that there probably is some sort of stigma associated with someone that's not HIV positive taking this new medication that they've now found out can also treat people living with HIV. So that kind of rears stigma into the conversation. Jay, how often do you encounter individuals that you want to have a conversation around PrEP with, talking about they'd rather not access the medication because of a stigma associated, for example, with it?
I haven't had anyone to just state that out loud, but I've kind of gotten that impression for some of my HIV positive patients from their partners. I've kind of gotten it from them, so I kind of just slide it in and just talk to them, let them understand, yes, this is what it is. And then a lot of providers don't quite understand PrEP either, because I've had some of my patients to come back and say, well, in the middle of the emergency room, they yelled out, da-da-da-da, and so when I talk to them, I try to explain to them, try to break it down to them so that they can understand, and they're able to explain to other people as well. So a lot of times they don't just blatantly say it, but you can kind of tell that that's what it is, and then I just kind of go into more education that way they don't have to say it, but then they still get the information.
I was going to say, I think we have a unique population that may not bring up the stigma as much. They're used to dealing with stigma. But I've done talks in the community, and I've heard lots of feedback, and maybe it's because of who I'm speaking to, but I've actually heard it more from females, that I'll be called names, prostitute, and those words that go with that. Those, if I take this medicine. And one of the, I think this came out of Croy recently, one of the conferences that talked about PrEP, that was saying that that's for not only for the patient or the client is the stigma, but just like Jay was saying, it's also from the physician or the practitioner. There's a stigma to even discuss it. We, as a society, as physicians, as nurse practitioners, don't do a really good job of sexual history, and so first of all, you have to be able to have the conversation, and then go from there after you have the conversation, and that's a difficult thing for a lot of us.
Sexual health conversation can be a little challenging, particularly because we live in Alabama, we live in the South. Cultural norms, along with not being able to discuss certain things, probably have some influence on that conversation. As a person living with HIV and bisexual, I think it's incumbent upon people like me to be loud about the subject matter, particularly because then it normalizes the treatment. What would you say around what we can do as providers and people in the industry to normalize PrEP? We don't really talk about high blood pressure and the treatment thereof, or diabetes and the treatment thereof, in such this broad window as we do with HIV. How can we begin to normalize the conversation, would you say? And I'm going to pose that question to all three of you.
But doing just what you're doing, to talk about it, to bring up the conversation, I think for us to take the conversation out of our office and into the church, into the barbershop, into different places where we might meet. I would love to see it in the school. Not sure that's going to happen in Alabama, but I think it's at least a noble thought. Those are the kind of places that we need to be talking about it, and so it doesn't become behind closed doors or just in the office, in a clinical setting, that we talk about it, that we just have conversations about it. And I think going where people are is a good thing.
Okay. Jay?
I think that's the best thing as well, is just educate, because like a lot of times, like when I have my patients that have the positive partners, after we have a talk, they be like, okay, I never thought about it like that. So I think it's really just a bigger part of people just knowing and actually understanding what it is.
Okay. Jonathan, what would you add?
I would add that how it's targeted, because when you think of PrEP, you also kind of connected with homosexual individuals or people in the LGBT community. I know that when I speak to a lot of heterosexual people about it, they don't know about it. I've spoken to doctors and primary care physicians about it before, and some of them don't know about it. But we have to open it up, because still to some people in some demographics that speaking about LGBTQ, so on and so forth, is a taboo conversation. And if we're putting PrEP inside something that's already so taboo, we have to spread it out. So starting with conversation.
And one of the ways that I can add that the Start Talking Alabama campaign has started to do that around our conversation is our program is digital in nature. You know, we have a following on YouTube, Instagram, Twitter, and Facebook. And so when individuals want to have that conversation, they can begin to have it with us. Shameless plug, I would say that you can follow us on all 4 of those social media mediums as well by using the hashtag StartTalkingAL. And so as we go further in the conversation, one of the things that I want to ask you all, tell me as a provider, what side effects, if there are any, associated with this medication, Truvada, that you mentioned. What would be side effects that I would be encountering possibly if I were to take the medication?
I think, and she'd be better doing this, but I think GI or stomach, I should say, side effects are the biggest ones early. And I'd be interested to know, did you have any? But nausea, bloating, some diarrhea. I think the long-term ones that we think about a lot and have gotten in a lot of press is thinning of the bones or osteopenia / osteoporosis and kidney problems. And so there are things that we do to monitor. One of the recent studies I did read said even if it does cause a little bit of thinning of the bones, it's reversible once you come off of it, so that's a good thing.
Okay.
And if you can get through those first couple of weeks, then you can actually tolerate it. Like I said, I'd be interested.
Yeah, so lucky me, I really didn't have any symptoms at all. I noticed dryness in my hands, but I would much rather be on the medication with dryness in my hands than not at all. I do have some friends, or one friend in particular, that when he began being on the prescription, that he had nausea, upset stomach, and some other things as well. But me personally, I didn't experience anything. It kind of was easy.
Okay.
The biggest ones that I get from patients are like she says, like the nausea. They just say it didn't make them feel well, but a lot of times that wavers about 2-3 weeks, and then a lot of times I tell them if they have it to eat with it, and that helps. I've had 1 or 2 patients that had headaches, but it resolved after about 1 or 2 weeks. Other than that, really haven't had a whole lot of anything else to occur with the patient.
So you talked about eating with the medication, for example. When you are putting a client on the medication for the first time, when you talk about diet and when you talk about taking the medication as you are prescribing it, kind of tell us what that looks like for a client, because we want to make sure we know that if a person's interested in taking PrEP, that it's important that they, for say, take it every day at the same time. Take it with a meal if that's necessary. So let's talk about that. Let's talk about how it's indicated to be taken each day if I'm someone seeking to take the pill.
PrEP technically is indicated to be taken daily, just as you take your blood pressure medicines daily. We strive for the patients to make sure that they take it daily and they're not missing doses. There are studies out there that show that they can miss a few doses and still be fine, but I tell my patients you might be in that 1 to 2%, so try not to miss those days. There's also a certain amount of days that they have to take the medications before it's actually effective for them. So in our males, we tell them to take them for a minimum of 7 days before it's actually effective. And in females, 21 days. So I always tell them that if you miss 1 or 2 days, you're fine, but after 2 days, you need to start that 7 days over.
Okay. That's a good idea, because it's always important to know that as soon as I take my pill, I'm good. No, there are prerequisites to knowing that you are protected in the most effective way as the drug is intended to do. So let's kind of move now.
Hold on, but just, because this was something I did not know, and this was from Croy again, that there is a difference, and I think she was alluding to that for males and females.
That's correct.
So males can probably get away with missing 1 or 2 occasionally, but females really can't for a lot of reasons. But the studies that were done when females did, those are the people that didn't do well on the medication. So really for, and that's, I know this is targeting MSM, but black females, I think, are some of the people that we miss in our target, and for a lot of reasons, we are at a high risk. And so that is part of the education that she does, that as a female you need to make sure you don't miss. And I think that's part of the group that we also need to target because of a lot of reasons. We may be in a relationship that we're being forced to have sex. There's all kinds of reasons, but that's another group that I think that we are trying to target at MAO as well. Yeah.
Anything to add?
She said we have, most of my patients are males, but our female population, it is growing. And so, like, I don't differentiate anyone, so I tell the males they're just as high as risk as they are with females if you miss your doses, so try not to miss it.
And it's interesting that you all bring this point up because we had a community roadshow with Start Talking Alabama where we talked about PrEP and several of the colleges here in the state. And we found that a lot of the participants who were inquiring tend to have been black females because they felt that they were not getting the information in real time, if you will. They weren't getting enough information about the availability of PrEP. How do I access PrEP? And so now, Jay, I'm going to ask you a question. How financially would I be able to afford this medication if I'm interested in getting it? And if there are programs that would help me if I'm not able to afford to do so?
Yes, we have programs as far as our patients with insurance. You know, we just file a bill on their insurance, but for our uninsured patients, when they come in for their appointments, there's kind of like a sliding scale that we use for payments. It's not real high. It's kind of based off of your income. And then as far as medications, each of the pharmaceutical companies, they have different programs that we utilize to aid the patients in obtaining their medications.
Wonderful.
So when they come in for their orientation, they meet with our pharmacist, and she completes all that paperwork and submits it. So by the time they come back to see me, we have it approved, and they're able to get their medications.
Wonderful.
That way.
Wonderful. And I would add that I'm sure plenty of the other clinics around our state offer similar programs to what you guys are doing at MAO. And if you want information about those programs, you can certainly go to alabamapublichealth.gov/Start Talking Alabama, and those resources would be available to you. I want to kind of shift the conversation a little bit, just a little bit, to you, Jonathan. As you have been on tour with the campaign and you have been able to touch some of the audiences that we're trying to reach to inform them, tell us how, even as an individual who's been on PrEP, how that's held you accountable to making sure that you're doing what the provider has said you need to in terms of taking your medication at the same time every day. Have you felt some of the pressure around making sure that you adhere as you're supposed to, or has it made it easier for you to do, for example?
I would say it's made it a little easier. I was persistent about taking my medication, but it has made it easier just because I'm speaking to people about it so much. It's, you know, PrEP has become part of my life.
Okay.
So it's very, very rare that I forget. To be honest, I do think I forgot to take the medication one night. One night out of 365 days. So, you know, it's, exactly. So it's bound to happen, but yes, it's made it easier.
Yeah, because the reality is we're human beings, right? Everybody forgets something sometimes. And we don't want to scare anyone, but we also want to make sure that we're articulating to the audience that it is important, that just as you get up every day, when you have the power to move, you want to take your medication as you've been prescribed your medication. HIV in this country has made leaps and bounds over the last 30 years. It's just amazing to see that we have a preventative now for the disease. And as a person living with HIV, I'm just really in awe of the last 9 years in particular of how much advancement we've made. Dr. O, you've been treating for a while. Tell us where you see us going and how you see us improving, say, over the next 5 years.
PrEP is just part of the prevention. So there's some statistics that just say if we just implemented PrEP in half the people that are eligible, we could reduce by 50,000 new infections. We could reduce that number.
Wow.
But if we add the other things, so there's PEP, so post-exposure prophylaxis in the 72 hours after exposure, add some more. And then treatment as prevention adds a whole nother. So we could actually Dr. Deal, whom we work for, says we have the tools to get rid of it. If we get the uptake of people to use the tools. So we talked about the PEP and the PrEP, and so the treatment as prevention. If we can get those people who are on treatment undetected, then they don't transmit the infection.
Okay.
So that's a prevention.
It is.
That is a prevention. So we have, and then condoms. Let's not forget condoms. They may not be 100%, but they're pretty good.
And let's take that word. You said undetected. Jay, tell the lay audience what a person living with HIV that is undetectable really means.
It basically just means that you have so little virus in your body that it makes it extremely hard to transmit. Doesn't mean that you don't have HIV any longer. It just means that pretty much you're taking your medicines and that you have very little virus in your body, which makes it really, really hard to transmit. And so that's why we have the U equals U campaign. Okay. Undetectable equals untransmittable. And some of my patients will ask that, so are you saying I won't have it? No, we're not saying that. We just said that you have it kind of minimized to a very, very low amount in your body. And so that's what I kind of explain to my patients so that they understand it better.
Wonderful. And it's important to note that even at undetectable status for U equal U, that person has to have been undetectable for at least 6 months documented. And so tell us kind of once a person gets to undetectable, what would you say to them their next goal in treatment should be?
Stay on their medicine.
Stay on their medicine.
Don't come off.
Right. Okay.
So until we come up with the cure, you will be on this medicine. And just like he has said that PrEP has become a part of his life, then, and just like my blood pressure medicine is part of my life, we want their HIV treatment to be part of their life, doing the same thing. So one of the things I think we do is every time they come in and get tested, get checked, and they're still undetectable, you get a hand clap, you get everything, because that is a great goal to stay that way. It's sometimes easier to get and stop your medicine because you start feeling good. But if we can keep you feeling good and stay on your medicine and become, just like you said, a part of your lifestyle,
then every day you know you have reason to get up
Yes.
and challenge yourself to move on. So you talked earlier, Dr. O, about follow-up screenings. You kind of hinted towards checking labs for the kidneys and for the bones. Jay, kind of tell us, if I have come to you and you've given me my first prescription, what would my second visit, for example, look like from a provider's perspective for me?
With your second visit, you would come back. You would have labs drawn that day. At the second visit, though, we pretty much just do what we call a comprehensive, and that pretty much looks at your kidney function, your liver function. We're specifically focusing on your kidneys, though.
Okay.
During that appointment, I also check to see how you're doing your medicines. I check to see how many doses of your medications you've missed. I check to see if you have any side effects on your medication. I also check for signs and symptoms of acute HIV infection. Okay. Check to see if you have any signs and symptoms of STDs. If you are having any signs and symptoms of those, then we check them at that visit. If not, we recheck everything, including another HIV test, at your third follow-up visit.
So routine testing for HIV happens third visit on?
Because the second visit, they come back in 30 days.
Okay.
So if some patients come back, they say, hey, I might have been exposed, then I'll do an HIV. But if they're fine, haven't had any hiccups, any issues, and they've been taking medicine, we don't do it at that visit. We just focus on the kidneys for that one.
Gotcha. Jonathan, this leads me to a question for you. You initiated the PrEP conversation with your provider. How was that experience? Talk about how that felt to go to your doctor the first time to say, I'm interested in this pill, and tell us since then how you've encouraged your friends to have those conversations.
Well, initially, a organization here asked me if I was interested in PrEP, and then, they connected me with the primary care physician.
Okay.
So having the conversation, I can't even recall when I was first introduced to the pill, but having the conversation, I was extremely interested in knowing more about it and to take that weight of, oh my goodness, will I be like a lot of individuals before me and have a day of where I get an HIV positive test back. So I knew that if this could, decrease the chances of me contracting HIV, that it was something that I was absolutely interested in doing and in pursuing. To speak about my friends, a lot of them know about it.
Okay.
I'll be 25 this year, so I'm still kind of in that millennial. Everyone laughs, but I'm still kind of in that millennial grouping or gap. And the great thing is that a lot of people, a lot of younger individuals, I can't speak to, teens or people who are older, but a lot of millennials know about it. A lot of LGBTQ millennials know about it. But then again, because as I think, me volunteering and connecting with organizations that speak about HIV, speak about knowing your status in PrEP, that opened that window to me knowing about PrEP. Okay. So then the thing is that people who may be low income or just don't have those resources or those connections to organizations within their state or community, how do they get to know about it? So I think that's a challenge, and I think that's a very that's a question that we have to ask.
And as we move through our Pride Tour, for example, with STA this month, that's one of the things that we're trying to combat, is that we want to make it a normal conversation for everyone. They kind of laugh at me when I'm out on Pride Tour, because I don't care who you are, where you come from, what you look like. I need you to pull out your cell phone and follow us, because there's information we have to give, as the approach that I take. And so as a provider, do you take those bold opportunities to encourage your peers to talk more about PrEP in just their everyday life, not necessarily in the clinic setting, but every day? Because as you said earlier, in order for us to combat stigma, we're going to have to start making the conversations around PrEP and HIV be an everyday conversation, no matter where we are. Do you do that?
Well, no. I don't need to start. I'm trying to encourage them to talk about it in their offices, and that's a big step for this area. Well, I shouldn't just say this area, though. That's a big step for a lot of providers across the United States to even to talk about it, to test. We want them to start the testing, and then once the test is negative, then go to the PrEP conversation. But we got to start with that initial HIV test, and we're still having hurdles from that. Something we just got from one of our colleagues, Dr. Manny, said that the CDC recommendation for testing has been around since 2004, and we still haven't gotten up to 50% of the people eligible that should be tested. Just tested. Not even talking any further. Just tested. Still not anywhere near that. So that's a... I try to encourage them to talk.
To talk in the clinical setting.
It's baby steps.
And it's honest, because that's what I think us getting over stigma is going to take, is the honesty and the candor of the fact that, even those of us who work it every day, live it every day, probably don't do the most important job that we have, and that's to share the knowledge that we have. Jay, would you say that that's a part of your friend circle conversation, or are you two just trying to get over that clinical hurdle?
Yes and no. I have a lot of medical friends, though, so we kind of talk about it from that perspective, and I kind of asked if they talk to their patients about it, and I just started doing PrEP in January, but for the ones that said no, I said, well, now they have somebody comfortable that they're used to, and I used to work there, so a lot of the patients know me, so tell them to come see Jay. So I kind of approach it from that way.
Okay. If I'm a practitioner who's interested in PrEP treatment and interested in getting in the field of HIV treatment, is there a way for me to contact you all at MAO to come and shadow you, for example?
Please do.
Send me an email at jellison@mao.org. They can call 334-280-3349.
Okay.
I can give you my
Because I think it's
number
important. We've got to encourage people. Family medicine is the norm. That's for most medical students. They go with the understanding that family practice is always something that's an option. But equally, HIV treatment.
Right.
In this society we live in now should be just as normal, right?
Right.
And so unless we encourage people to go into the field, I oftentimes laugh about how our creator had this sense of humor, because I hated science growing up. Failed in most of my science classes with a C in my mind. That's a failing grade. But here I am. I live it every day. I breathe it every day. And so it's interesting that my full circle did come close because now it is every day for me. You know, there's probably not many moments that I don't spare to be able to talk about it. So as we go into another question, one of the things that our audience asked us earlier is, what would be innovative approaches when we talk about this PrEP thing? You talked about a lack of black females being informed. How would you offer an innovative approach to being able to attack that issue?
Well, I think some of the things that we've already said, the church, going to barber shops and beauty shops, but I also think we need to go into the rural community, and that's a whole different kind of ballgame. So we have connected with a few rural communities, in Lowndes County, those kinds of areas, to try to find out what they think, where we can go, where they would be comfortable for us talking, because I grew up in D.C. I don't know a whole lot about rural, so I need to know from somebody who lives there, and so I think to open up the conversations that way. Rural Alabama also tends to have less physicians or nurse practitioners, and so we've tried to connect with them as well, the few that are there. So let me educate you, and you tell us how we can get into your community, how we can start educating your community. But I think we need to connect through our social groups. So I do a lot, I'm a member of a sorority. I do a lot of education through my sorority, which reaches lots of folks because it's a big sorority. So we do a lot of those kinds of things, you know, through our own connections. And I think that's a good way to start, to use all of those kinds of connections, everything we got. So,
okay. Yeah. Because we're always looking for different approaches. So thanks for those offerings. Jay, do you have something to add?
I think, as Dr. O said, to kind of start with the schools, in particular the high schools, because I have a lot of the newer patients, and they're getting younger and younger. So I think that would, if we could possibly get in there, I think that would be a good thing as well.
Okay. Jonathan, our millennial.
Yeah. I would add to, you said high schools, but I'm going to be the person to say even younger, even like middle schools. I think that a lot of parents are under the impression that they're the ones that come to their children to bring up the topic of the birds and the bees, aka sex. But a lot of times 11, 12-year-olds are talking about it before their parents even know. I grew up in St. Louis, Missouri, so I don't know if they have sex ed classes here in Alabama. But I think that's another beneficial thing. I know being in sex ed class that I was scared to be sexually active with someone, petrified of it. So after getting out of high school and getting in my 20s, I made that decision. But if we start there, start when they're younger. And I know I don't have children myself, and I know from a parent perspective that is a scary feeling to kind of have that conversation, and it's uncomfortable, but it's a conversation that's needed to be had. And if you start younger, then, you know, when they get older into high school, then they're able to educate others about it. And that is one of the things that how we can stop the epidemic.
Okay.
One of the things you had said before the program, that I think one of the Pride events in Auburn was so family friendly, and I'm very impressed with that, and I think that is a way. We had a event at MAO this past Saturday for National Testing Day. They had lots of things to do for kids, and so I brought my grandkids, and I just think that we can do age-appropriate education and make those kinds of events family-friendly, and do the education that's a way to start to get to talk about it.
Right,
yeah.
Because it makes everyone comfortable in the conversation. I want to go here if I can. We know that we have kind of peaked with the epidemic of HIV at this point. We have new infections. There are other demographics that probably have increases in numbers, but for the most part in this country we've peaked in terms of new infections. what would you say in a perfect world it's going to take for us to end the epidemic of HIV in America?
I think it's going to take all these things we've asked and some more we've talked about. It is not a one solution.
Okay.
I think all of them together. I think to get primary care providers on board. I think to get legislature on board. I think the school system needs to be on board. I just think it's going to take the whole community saying we got to do something and doing.
So the whole of America.
The whole of America.
Jay, something to add?
Make America great. Okay, I'm sorry. I'm sorry. I went there.
No, I think she just about said it. Like I said, you can't do one part without the other. You treat this person, then you're still not doing the testing, and there's still the ones out there that's not getting tested and may not know that they're positive. So I think as a whole, is just kind of pushing everything and trying to get everybody. If we do a little of this, a little of that, and a little of this, then we can go from there. And then once we get them all, hopefully we can do 75% of them all.
So I hear you both saying this is not an I, this is a we issue. Because oftentimes people living with HIV, people at risk for HIV, feel the stigma associated with it is that it's about just you. It's just about your population. And Jonathan, you talked about LGBTQIA plus individuals. We feel like it's our epidemic. No, we know that the numbers show totally different than that. So then where, as we are educators for tomorrow, where can we then speak those truths more broadly, you think? Jonathan, I'll ask you first.
Oh, we'll start with me. Where could we start? Where could we speak?
And I'll help you. We've, with Start Talking Alabama, we initially started just on social media, for example. We found that, yes, we reached an audience, but we didn't reach a big enough audience. We felt to be able to get the target population that we mentioned in the opening. And so then we did a town hall forum. And we saw that the numbers increased. And then we added the uptick of the Pride tour, for example. And we saw an uptick of numbers. And we saw people getting more engaged. And then we also saw the demographic start to open up in terms of gender, race, and orientation distinctions. And then now we have a community roadshow that we're doing on college campuses. So we've recognized, even at Start Talking Alabama, that there is a more broad base by which we need to paint our brushes. So what would you say, as we've gone forward, or as we move forward, would be offerings that you could recommend to us as we move forward in the campaign?
I think we're moving in the right direction.
Okay.
I think that we are really hitting every bullseye to get the solution. We would Start Talking Alabama, we haven't limited ourselves on who we speak to or what demographic we are catering to. If anybody is willing to listen, then we're willing to speak. And with you, Doctor, how you stated that you speak to your coworkers and colleagues, just starting in the office. Right. It's those things, the smaller conversations is in a restaurant, it's there. Just having the conversation any and absolutely everywhere. That's what we do.
I think college campuses, though, is a good place because when you get the college students together, I mean, we can see that gun control has now become a big topic because the young folks made it a topic. Us old folks, we knew it, but we weren't making it the conversation. And so when you get young folks talking, that's a good thing. But you know that I believe in the church, particularly in this area, that has to take a stand.
Right.
And that if we can get pastors talking about it from the pulpit, and not in a condemning kind of way, but in an educational kind of way, I think that the Bible Belt will benefit greatly from
I want
that.
you to look at that camera right there, and I want you to speak to those pastors just the way you just did it, directly.
I really want the pastors to start to educate themselves first, and then they can educate their community and their people, because we listen to our pastors, we do. And if we can have the conversation from the pulpit, that we need to be talking about. Again, not from a condemning point of view, but from an educational point of view, from a public health stance, then I think we can make inroads into some of the things, and we can get out of the closet and the shame and the stigma that sometimes the church itself has
imposed upon us as a society. So I would say to our audience that in about 10 minutes we're going to take a break. So if you have questions, we ask for you to call in. We ask for you to send an email. We would welcome you into the conversation as we come back from the break. But for our panel, I want to ask this question. I want to say, again, thank you all for what you've offered in the conversation so far. And thank you for choosing to be here as a part of our panel today. But most importantly, personally, I say thank you because as a person of color, as an advocate who has chosen to make myself available to the community for the disease that I live with every day, it is welcoming for me, it is encouraging for me to see people like yourselves willing to step out. Because sometimes this role, this cloak feels like I'm alone. And so I think part of that, being able to normalize the conversation and speak directly to people like you just did in the church, is only going to be what's going to make brown folk feel that this conversation was meant to be for them. I think I've got a question that just came in. Let's see. Yes, we do. We have a question. Steve?
So we do have a question from one of our viewing audience, and it is, people are not educated about PrEP and how it works. Some people feel that PrEP is a scientific study, which leads to HIV. How do you alleviate the fear regarding PrEP, especially among African Americans who are constantly bringing up the U.S. syphilis study?
Wow, Dr. Owens, they went right at you.
I'll do what I can. I understand there is a lot of fear associated with the stigma. I'm old, so y'all are a little bit younger than I am, so I do know and was very privy to meeting patients when I first moved down here who had been in the syphilis study. So I understand there is a great fear. But the overwhelming evidence shows that if we just become, like I said, we just look and read some of the evidence, the overwhelming evidence shows that this is not anywhere akin to the syphilis study. That this is real. People like you can attest to what can happen with HIV infection, and people like you can attest to what does not happen. Sometimes I think, like I said, because I'm old, I have a little bit better perspective because I remember in the 80s when folks were dying. I told you, my best friend. I'd have done anything in the world that I could to have her not die. She was a brilliant doctor, and she still died because we just did not have the tools. So I've seen this come a long way, and it is not anywhere at all like the syphilis study.
Okay. And I appreciate your personal candor there. Jay, would you like to add something?
I guess I can just mostly say with the PrEP patients in general, that kind of proves that it's not what they did with that particular study, because we're doing the HIV test when they come in and they're all coming back negative. So if it was that, then they would be coming back positive. I have very few patients who's been on their treatment and remain on their treatment and ended up positive. I don't have any. So that in itself, the results that we're getting and the patients that we have, and our numbers are constantly increasing as far as new patients. So that in itself should kind of hopefully give them some encouragement that, it's not that.
And the monitoring that you do to make sure that there's no problem. So the kidneys, I mean, if some people say that's even over monitoring, but there is a lot of monitoring done with this to make sure that there's no complications related to this.
Yes.
And people are living and doing well. And looking as good as Jonathan. They're doing well on this. This is not the same at all.
He has a glow, doesn't he?
Yes.
I thank the audience member for that question. I think it's important, particularly they're speaking to a culture of Alabama. When we talk about the syphilis study in Tuskegee, I think it's important to honor that still exists among our conversations in our communities. But it's also important to note that I am a person living with HIV who took 29 pills every single day when I first was diagnosed, and now I take a single pill, and that has happened in 9 years. That's how great medication advances within the disease have taken a part. And I'll, for full disclosure, tell you that yes, Truvada was part of my original treatment regimen. And I had a fear of changing because it worked. God kept me here and I wasn't trying to change nothing. So I had that conversation with my provider. I'm like, why do I need another pill? Why do I want just one pill, for example, when 3 are working? And she was very encouraging to say that while you want to make sure that your regimen is working, you also want to make sure that you're taking the best treatment. And so as we've advanced with treatment, let's talk about how as we're treating patients, that we still need to have conversations around, are we taking the best treatment for us right now? Let's have that conversation. Dr. O, because you know that at this point in your treatment as a provider, that you've seen where you had to come up with 3 or 4 medicines to treat a patient, and now their initial treatment is 1 pill. Kind of talk about how you had those transitional conversations with your clients.
And some of them are difficult, just like you said, because I'm feeling great on this particular regimen or these 3 pills, and why are you trying to change me? And I remember before these 3 pills when I wasn't feeling well. So I have a lot of times, it is a difficult conversation, and sometimes it's not going to happen on one time. Sometimes it takes several visits, but we just do try to go over. We're trying to minimize the side effects. The medicines work. That's the thing we can say about HIV. There is treatment out there that works. We just want the one that has the minimal amount of side effects for that person.
Right.
And that's the individual decision that we have to talk about with each patient. And so I think we both have that, and all of us have that conversation. And sometimes, again, it takes more than just one conversation.
Yeah, sometimes it takes 2 and 3 visits, but you just add a little. And this visit, they're a little more interested. And you add. Sometimes you even send in a prescription, they say no. But you just kind of continue to talk to them and just kind of give them the facts. And a lot of times that does. It takes time. It takes a while sometimes. But for the most part, as long as you educate them and provide them all the information,
They tend to be at ease. I think we've got another question, Steve.
We do, Warren. This question is, where is the national attention on PrEP, or why is there not national attention on PrEP?
Okay. That's an interesting conversation. I will say for the South that there is national attention on PrEP. We've got a new Compass initiative that is a 10-year initiative that is being provided by Gilead Pharmaceuticals, for example. And I know that if you're interested in finding out more about that initiative, it's COMPASS initiative, that you could talk to our partners over at the Southern AIDS Coalition, or SAC, if you want to Google them. They could give you more information about how that program regionally is going to be implemented across our states.
But this is not like we've come out with a new diabetes medicine, though. There is still plenty of stigma. So to even have the conversation, first you have to admit that there's a problem. You have to have that part of the conversation, and there's still not a national, it's not every day. You know, when years ago, it used to be in the news every day. It's no longer in the news. It's no longer part of that conversation. So a lot of people just have put HIV out of their mind if they're not dealing with it on an everyday basis. They don't even think about it, and that's including providers. So the national conversation needs to start from the caller. The national conversation needs to start from each one of us. You know, this has to be something that those of us who know do continually try to talk about and bring up. And I still say the legislature has a lot to answer for and needs to be aware. And I don't think that's being done. So all of us it's on all of us and on us to step up to the plate and make it part of the national conversation. But I do think it is, there is some uptake of PrEP, but it certainly can do a lot better.
Okay. Jay, did you want to add anything? Jonathan? I will add a challenge. You know, June the 27th, which is tomorrow, is National HIV Testing Day. I'm going to challenge our audience, our panel, our internal audience, that all of us tomorrow will make a post about PrEP and about HIV testing. Because at least it starts with us. And if we're going to be the ones to talk about it, we need to be the ones to be about it. So let's all make a commitment, audience included, that we will post about PrEP and HIV testing tomorrow in honor of National HIV Testing Day.
All right.
I think that's a good way for us to go into our commercial break, take about a 10-minute break and come back. We would ask that you all would join us in about 10 minutes for the continuation of this conversation. Thank you for joining us so far. We want to welcome our audience back for the rest of our conversation. And once again, I want to encourage each of you, if you have a burning question that you've had on your mind since the beginning of the telecast, or you've come up with one during our break, please either email us or call in directly. We'd love to hear from some of your voices across our viewing audience. At this point, I want to go back to Dr. O, and I want to ask a question that we kind of had a discussion about during break. Tell us what parallels you see between the introduction of PrEP as prevention, as well as the birth control pill as prevention when it was introduced to our modern society, if you will.
So there are a lot of parallels. When we first were introduced to birth control pills, people were afraid of it, thought it would make people more promiscuous. It was, if you were on it, you must be doing something that you shouldn't be doing, all of those kinds of issues. And now birth control pills are just everyday living. It's you know, no big thing. If you see it, if we take it, some people take it right in front of them. It doesn't matter because it's not a big thing. So I think that PrEP will get to that point. We're not anywhere near that. We're just as we were at the beginning of birth control pills, that all kinds of stigma if you're taking it. Sometimes people don't want to reveal that they're taking, just like they didn't want to say they were on birth control pills because of the stigma that's attached with it. But just like birth control pills have now become part of our everyday society through education, through talking about it, through more physicians and nurse practitioners being willing to prescribe it, I think PrEP will get to that point as well.
Okay. Jonathan, I'm going to ask you that question very specifically. Has there been a moment that you felt some sort of stigma around the fact that you take PrEP, for example, each day, and how it's received by your peers and the broader community? Have you ever had that moment that you felt you couldn't share because of that?
I haven't had that moment where I felt as though I couldn't share. And when speaking to my peers about being on PrEP and some of them being on PrEP as well, there's never been a, oh my goodness, you must be promiscuous type of thing. The only kind of setback I had was when I was speaking to the primary care physician for, I think, my initial consultation, that it was, if you're an individual who has I forgot the wording, but there was a particular wording used of kind of saying, or if you're promiscuous, or if you have multiple sexual encounters. That was one of my things, because I said to myself, well, I don't have sex often. You know, if I am intimate with someone, it's that person for a long period of time. So then I kind of asked myself, well, can I be on the medication being that I'm not promiscuous or out, having sex with multiple different partners in an evening or within a week?
I think that's important to note, because, Dr. O, you said the stigma associated is that you must be promiscuous. And Jonathan, you brought up the point that I'm not a highly sexually active person. Jay, you as a coordinator of treatment, tell us what that looks like for you when you're talking to a client who, like Jonathan, may not have a lot of sex partners on a routine basis versus somebody that you would talk to around someone who admits that they do.
Well, I kind of try not to individualize somebody so they don't feel like that. But if it's one person that, in Jonathan's case, where they don't have sex that often, but they do have sex, they're still at risk. You can have sex at one time and you are still at risk. So if I have a patient that doesn't have intercourse that often, they still want to be on it, I don't encourage them to come off. I just give them the information, say, hey, yes, if you have sex at one time, you're at risk for HIV. And so they still pose that risk. Now, this patient over here, if I know that they're highly active, I may try to encourage them a little more, like if they're trying to come off, I will encourage them a little more to stay on it. But I wouldn't tell them, hey, since you're not, I don't do that. But I do let them know that how it was designed, what it was designed for. It was designed according to your risk factors. But if I have a patient that says, hey, I still feel like I need to be on this, then obviously they need to be on it.
And let's talk about that for just a second, and then I think we've got another audience question. You talked about coming off the pill. So if I'm a person taking PrEP, I'm able to stop taking PrEP?
If you like. I kind of take that as a case-by-case basis as well. If it's somebody in Jonathan's case, they don't have as much sex and they feel like they're not at risk and they would like to come off, I provide them with the information. We make sure that that their hepatitis status is still the same, because, as you know, Truvada is a medication that we use in our HIV patients to treat hepatitis B. And so if we just pull them off and they have that, then they can have flares from it. So we verify that, but we just kind of educate on the patient, let them know that they truly and really understand what they're doing and what the ramifications may be behind it. And then if they decide to come off of it, then it's their choice. But once again, like I said, if I have that one that I know is highly sexually, they have multiple partners, I try to do a little more education with them and make sure that they truly, truly understand what it means to come off of the medication.
Okay.
I just wanted to ask Jonathan, because a lot of the times what I see is the stigma comes from family. It may not be from your peers. Families can be, So did you have any issues with your family?
I'm glad you asked that question, because surprisingly, I haven't spoken to... I think I may have spoken to my grandmother about it. I am on a family insurance, so a little bit of backstory, and I've spoken about it in previous videos, but I was adopted when I was 4 by a gay man here in Birmingham, Alabama, who is now married. So I think I educated him about PrEP. And so my dad was around for the huge kind of HIV/AIDS epidemic. So when I spoke to him about it, he was pleased and he was proud that it was something that I was interested in. Now, he did have kind of questions about it himself, and will there be any future complications? And I think. So he did kind of have some slight reservations about it, but more than anything, those individuals were pleased that I was interested in it.
Well, that's good. That's good to know, because family support means a lot to us, right? And especially in the South, we look to pastors. But we also look to mom and daddy. Mom and daddy are the validation for it all. And so as long as they're happy with everything we do, then we know life is good, right? We're going to go to Steve now. You have another audience question?
I do. We have a couple audience members who have asked a similar question, so I'll pose them both together.
Okay.
And that is, what's the minimum age that someone can be prescribed PrEP?
Okay. Let's tackle that one first. Jay, you want to go there?
That was actually just changed, I think, in maybe late March.
Okay.
Originally, it was age 18. Now it's been improved in adolescents, but I think they have to weigh at least 70 pounds.
Okay.
So there's really no particular age on it at this particular point. They most are base it off of weight.
Off of weight. Okay. All right.
At MAO, right now we're still currently seeing 18, but we're trying to get the logistics and everything in place, and then we're going to try to start doing it.
So
as well.
18 and older for your particular
For right now,
organization.
yeah.
Okay. All right. Steve?
Okay. And then a couple of viewers are from academic institutions, and one asks, how can we best get PrEP onto academic campuses? And then the other is connected again, is as an employee of a public university, where can they direct students to obtain information on PrEP, and especially wanting to know if there's print material available and how they'd go about getting it?
Okay. I will start with that conversation, or the answer to that question that came in, and say that if you, again, would link up with us on our social media sites, be it YouTube, Facebook, Instagram, or Twitter. You can follow us using the hashtag StartTalkingAL, and we provide resource locations for PrEP treatment. PrEP resources are available on our streaming of those sites. And then if you want to go to alabamapublichealth.gov/StartTalkingAlabama, you'll find kind of in the middle of that page links to your particular area. So if you're South Alabama, there would be resources in South Alabama. If you're Northwest Alabama, there would be resources that that link would lead you to in Northwest Alabama. So anything that you all want to add to that in terms of how you think I will pose it in a different way. How can we do a better job in medical school in making PrEP a part of academic learning?
One of the things that MAO that we do is we have a lot of students that come. We have our nurse practitioner student with us, but we see students every day from nursing, nurse practitioners, and residents. So we have tried to incorporate in their education how to get about PrEP, how to access PrEP, and HIV. One of our recently added colleagues was a professor through UAB and teaching the residents. And so he has done a lot to promote and to allow us to get into schools, or at least into that medical school, to educate on PrEP. Since I'm not in an educational setting, I'm not quite sure what else could be done other than to try to educate.
Well, I know one thing, we have a good outreach department, and Monte does a lot with getting out to the schools. So for those ones that came from the academic responses, if maybe they can leave some contact information, I can get it to them, and he'll reach out to them because he's been wanting to do that. I mean, so if there are employees there, that may be a better foot in the door. So if they would like to leave their information, then we can get it to them, and hopefully, in this area at least, go from there if they're in this area. And
I would also encourage our viewers to note that we have the Southeast AIDS Education Training Center, which is housed at Vanderbilt University. However, we have an Alabama wing that's called the Alabama AIDS Education Training Center, and they are housed at MAO. Right. So that would also be another location where we would have resources for individuals if they wanted to reach out about that. Any other questions from our...
We have one viewer who's asking, the acronym MAO has been used quite often in today's panel, and they'd like you to define what that is, who that organization
MAO.
is.
So I'll let the two of you define what MAO stands for.
So let us apologize for not.
Well, I said it earlier. That person may have joined us a little later after the introduction.
It's gone through several changes, so the most recent name is Medical Advocacy and Outreach, and the reason is because it used to be Medical AIDS Outreach, and we used to treat just HIV, but we do now PrEP, hepatitis C, and hopefully diabetes soon. So there'll be different umbrellas or treatments under Medical Advocacy and Outreach, and so that's the name of the organization that Jay and I work for.
And I would also like to have you all talk about at your organization, based on what you just mentioned, if I'm a client that comes in for whole health education and treatment, is this the location that I could choose for myself? Or do I have to be a person living with HIV or at risk for HIV in my mind before I can come to MAO?
At this point, we are treating HIV and those at risk for HIV.
Okay.
As I said, though, we are hoping to branch out, and our newest initiative is diabetes. So hopefully that will spread. So at this point, yes, you still have to have either HIV or be at risk.
For HIV.
But we also, once you are in our care, we treat the whole patient.
Okay.
We don't treat just HIV. So if you have other things, high blood pressure and cholesterol and diabetes, we do all of that under our umbrella, under our treatment. So.
Wonderful. So my whole health gets attention
Yes.
if I'm a person living with HIV, just as much as anybody else would get at their family practice
And
physician.
actually more.
Okay.
That's why that might be my
appreciate that.
bias.
I
but,
appreciate that.
I did do private practice for 25 years, and I never had direct access to a social worker. My gosh, that's just such a wonderful thing. There's a food bank. There's the dentist.
Mm-hmm.
There's all kinds of services that I wish I had had. I may still be in private practice if I didn't, but I wish I had had that. That's just I think MAO does an amazing job of taking care of the whole person.
Okay. Well, thank you for that information. I want to pose this question. As we look at our calendar year for 2019 with Start Talking Alabama, what would you like to see our program do from your provider standpoint? How can we help you educate our community better?
I like these kinds of forums. I would like to see these forums go to the colleges and perhaps having even some of the college students on, because they bring their own crowd, their own crew. I think going out in the community and doing, social media, even though I'm old, even I'm on social media, so I did it again. I'm on social media. So I think a lot of us do use social media, and I think it can be used in such a wonderful way. And so going out in the community and taping things and then putting, that's how people make stars these days, out of one little person in their backyard or something. So I think that's a great way to start.
Okay. Jay?
For the most part, I think that would be the best thing. I think we did a block party this year or something this time. I think that says a lot for the community, kind of opens up conversation about it, and it gets people talking a little more. And like she said, maybe including the younger population, like I said, the millenniums, in these types of talks.
Duly noted, Jonathan. All right, we're going to go to Steve for another question.
We do have a couple more questions. The next one is there any data that shows there's an uptake in STIs among people who are on PrEP?
Jay, I'm going to let you tackle that one, because that's probably coming along with that stigma association with you must be highly active if you're someone who's interested in taking this pill to prevent.
I'm not totally sure if it's, I don't really feel like we can honestly say that, because we're testing them so we see theirs. Other people are not getting tested, and so they may have just as high as rate. But we do see a lot of STDs with our PrEP patients. We do.
Yeah, and there are some recent that just came out this past CROI. So I'm not sure if they're asking about from MAO's point of view or from nationally, but nationally, I would have said 6 months ago no, and now the new data says yes. There are more STIs, and one of the proposed things, or there's a few of them, but some of it is that, again, there's the stigma about being on PrEP, so you don't want to say that, and that may turn someone off. There is some, and I'm blanking on the term, this is age, but I can explain it, maybe I can't say it. There, in black MSM, there is less of an opportunity to have sex because you're having sex in your own community, versus white MSM is a bigger community. So if you have, let's just say 10 people, and one of them has an STI, versus this community has 100, and one of them has, these people in this 10 have a much more chance of getting an STI. So yes, there is a higher incidence of STI, not necessarily higher number of sex partners, but a higher incidence because the community is a little bit limited or closed, I would say.
And I would say part of what Jay said to that is that because you're testing regularly, and that's the message we want everyone to take away from today's conversation, is that testing is key no matter what disease, right? Being able to say that you routinely see a physician or a provider for your health, no matter who you are living in this country, is necessary. It is important. It just so happens to be that our conversation today is around PrEP and HIV prevention, right? And so, Steve, is there another question from your audience?
There is. This viewer would like to know, from a legacy perspective, we see that PrEP, the conversations around PrEP and a lot of the marketing about PrEP is primarily geared towards white males. Why is that, and what's being done to change that?
Well, I'll say one of the things that we have struggled with at Start Talking Alabama is striking a balance around race, because obviously that plays a part in our everyday living, right? We still identify and recognize we're in the Deep South that had its race issues in times past. And so while this campaign started as a target for black men who have sex with other men, not necessarily who identified as gay, but that just who had sexual encounters with other men, we quickly found that we were not the only population of people who needed the information. And so one of the things that I would say to your viewer, Steve, is that while it may appear that some of our programming just targets a particular audience, understand that no matter whose face is on the information, what's important is the information that we're sharing. Because that's what's going to save lives. That's what's going to change lives. That's what's going to affect our abilities to access care. Because ultimately, that's what we're here for. We're trying to encourage people to access care, to have a better care, and be their own best advocate around their own personal health. Whatever choices they make, that's fine. But know that you're doing so healthy. Would you want to add to that?
No, I think you said it. I do think part of it is still how the community that HIV was first seen in. And so a lot of times we still want to say that's their
White
disease, right? And so that's their problem, not ours. And unfortunately, because of that, that promotes the lack of education about it. So I do think that's probably why. I also think the people who have taken advantage of PrEP, actually, statistically speaking, has been white male. San Francisco is a great model, I guess, because they have long-term stats that say new HIV infections have gone down tremendously with the uptake of PrEP. But they have, because they've done it for so long, they have lots of education from all those things, all those groups that we said, the politicians. They've got everybody on board. And so I think because of the history, because of the legacy, that we have categorized who should get PrEP and who shouldn't, and those kinds of things. And I think that's probably why the caller still sees it from that point of view. But I do think ADPH has done marvelous to try to bring it to our community and educate our community as well.
Any other questions?
We do, and these two questions are directed to specific panelists. The
Okay.
first question goes to Dr. O and Jay, and it is, are you open to coaching other providers in becoming HIV testing and PrEP champions such as yourselves?
I am, yes.
That's a yes. That's a yes for the two of us and everybody else in our agency. We're excited to teach other folks about it. It won't get us out of a job. We'll still have a job.
And once again, I would say, if one of you can give contact information, since you have dedicated your lives to championing this work, how people can get in touch with you.
Okay, now, the way you can contact me, you can send me an email directly at jellerson@maoi.org, or you can just call our facility at 334-280-3349.
Give that number again.
334-280-3349.
Thank you all. Thank you all. Steve?
So this next question goes to Jonathan. It says, what would you say to someone who's interested in using safer sex practices but is fearful of what their family and friends might say in terms of judgment of their desire to be intimate?
To be intimate with who? I think the thing is we're talking about safer sex practices. That is still very personal. So I don't understand the relationship between that individual and that in their family. I think it's something that they have to make the decision for themselves. Yes, you may have a close bond with your family, but at the end of the day, you are the person that you are, and you make the decision for yourself. So if that's something that you are interested in doing, absolutely make that decision for yourself.
And I think it's important also to add to your point that family looks different for all of us.
That's right.
We take for granted that individuals who may be a part of our audience have biological families, and that may not be the case. They may have chosen families. Jonathan, you spoke about being adopted. Our audience, we really don't know why or how they're sitting with us today. So as a panelist, what would you say in terms of a person who's wanting to access care for PrEP and or HIV treatment? What would you say is important about facilities being welcoming no matter what my familiar background may be?
I think we all believe that it is very important that we not present even unspoken stigmas, unspoken things that said you're not welcome here. So we try to make sure that does not happen, that everybody feels welcome. I was just going to say to that last question also, though, Jonathan took the time to educate his father. And so that's what I think sometimes, and I'm not saying that everybody just needs to come out and do it, but if you feel that you can, then I think that's a time to educate. I think we can all be educated, and this would be a time to educate your family on what PrEP is and what PrEP isn't. So it doesn't mean I'm going sleeping with everybody just because I'm on this. This is to protect me, and you want me to be healthy and be the best that I can be. So to start the conversation, maybe not about me. We all do it. Go to mama and say, Sue down the street is this. And so to start the conversation in general with your family, whoever the family may be, would again be a time to educate and then maybe work them into
the personal.
Right.
Yeah. Because I'm inquiring about something doesn't necessarily constitute it's personal.
Right.
Right? And so, again, that's normalizing the conversation. It's making it seem and appear as if we're just, as a community, having conversations around prevention, which is what we can all use more of at home and all of our homes. Are there any other questions from the audience, Steve?
At this time, I would encourage our viewers, though, we have a couple minutes left, so they may want to pose the question.
As we come to a close in about 5 or 10 minutes, I want to ask you all some personal questions around being a part of this world of HIV. Because, I can speak for me, it never gets old to be able to get up every day and voice how I feel as a person living with HIV, because I think it's not enough of that. But you're a provider who's stated you've been around for a while. What would you say to someone like yourself to make sure they're encouraged not to have a burnout or to give up? Because we truly are seeing great progress. It's just not as fast as we would hope, right?
Right. My inspiration comes from a lot of things, but my inspiration comes from people like you and people like you. People who are living every day and not dying every day. They are living. And so I think to keep from the burnout, I look to people like you. I look to have conversations with the Jonathans of the world. I look to encourage each other. And so because we deal with different kinds of things, but the same thing, and some of them the same every day. So I look to encourage each other. And then sometimes you have to step back, though, and make sure that you yourself are not the cause of your burnout. You just need to sometimes take this time to make sure that you're healthy as well.
So self-care is important, just like it is for the clients that you're providing care for every day.
Every day.
Jay?
Like she said, the self-care, I kind of look to a lot of my patients, too. I actually have one patient that I call my miracle patient. I got him when I first started doing HIV care. But he came in, he was in a wheelchair, he couldn't walk. When I first time I walked in the room, he did this to me, and that was it.
Wow.
He walks now, he talks now, does pretty much everything on his own now. And so I kind of use him, and I have a few other patients as well, but I kind of look back over those things, and it makes you good to know that you did that. You assisted that patient in getting his health back, and so I kind of just use that.
So you feel like you've built a team relationship with that client, because now you can see victory just as much as they can call victory, right?
Yes.
Jonathan?
I guess it would be for those individuals that are kind of feel like they're at the end of the rope or feel like giving up, is knowing self-purpose and self-worth.
Okay.
And always, because it's so easy to get kind of caught up in a tornado or a distraction of life situations and life circumstances. So it's knowing purpose and knowing your self-worth, and knowing that, having a game plan for life, having a game plan when you wake up every single day, when I fall asleep, what do I want to accomplish today, or what do I want to accomplish in life? And when you remember that, you always can kind of go back to that idea and back to that thought of, it's giving up is the easy route.
Right.
Challenge yourself.
Right. I think we have a caller that's wanting to ask a question from the Birmingham area. Caller, are you there?
Yes.
Go ahead with your question. Please state your name, your first name.
Molly.
Okay.
Do you have any experience?
She kind of faded on us, guys, in the control room.
Like their parents' insurance, seeking PrEP services, and their parents aren't aware that they're gay?
Can you repeat your question? We were having slight technical difficulties, and I want to make sure we answer all that you had to ask. I'm going. Go ahead.
Do you have any experience dealing with clients less than 26 years old who may still be covered by insurance?
Jay, do you want to answer that question and what that means if I'm, for example, because of the way the healthcare program runs now, if I'm up in school up to a certain age, then I'm still potentially on my parents' insurance. Can you talk to how that works for your for your organization, for example?
From what I gathered, it sounds like she was asking, how do we go about that if the patient is on their parents' insurance and they don't know?
And they don't know, right.
We haven't actually run into that particular situation yet with the actual patient. I think we have had some people to call and ask about that.
Okay.
So we're still trying to work around logistics with that. But there are a couple of providers that I conversate with who they've had that issue, and sometimes with some insurances, they tell me that they can call and kind of talk to the insurance company and explain exactly what it is, so that they show it on the explanation of benefits on the bill, but they show it kind of discreetly, so they don't specifically state what it is.
Gotcha.
And sometimes that works, and sometimes it doesn't, because when the parents are not there, sometimes the insurance company, they shut you down automatically.
Right.
But she mentioned that they had quite a few patients, and so with certain insurances, they had no issues with getting it done, and then others they did. Like I said, we haven't had to specifically do that just yet, but we're trying to gear up for if we do have that problem and what we would do and how we would go about it.
Gotcha. Thank you. That's helpful information, Jonathan.
So for individuals that may come to either of you, I know I am insured, so with the process of getting on PrEP, it's a little bit different. But let's say there's someone who's 22 and their parents aren't aware of their sexuality, and so could they go about the means of getting PrEP as though they're uninsured?
I don't know the exact answer to that because our pharmacists deal with that, but if they're showing up on an insurance and we try to do the application, I think there is a way for them to find out that the patient does have it. But then again, we have some people that has like kind of like an off-label insurances that won't cover it. And so there's a workaround that our pharmacist does to do that. But it still shows that they have insurance, but once we verify that it's not covered, then they can switch over to the pharmaceutical assistance.
I do think that's also regional, and I think she's right for Alabama. Washington, D.C., which is, I told you where I'm from, has a clinic that they have established a fund through donations where they, if you do not want it to be on your insurance, then it will not be on your insurance. But I do think here that we are required as of right now to report it. But they have a separate fund, and so everything is funded through that funding. So their parents, if they choose, don't choose to tell them that they don't have to.
And that brings about another question around disclosure. You know, we've talked about accessing care, but if, as you said, Jonathan, I'm not ready to come out. You know, this is National Pride Month, and I don't want my parents to know that I have been engaging in sexual activity. How do you all deal with your clients where they are in their ability to share but still want to be healthy? How do you deal with that? Or do you even have such case that you've had to deal with it?
I have, and that's usually for HIV. I've had that. And so it does take education. It takes, I actually call in one of the mentors, the educators, who has been through it already. And there's a class that they can actually take on if they choose to disclose, how to disclose, who to disclose to. So I bring in all the forces that I can because I can't make that decision for anybody. They have to live with the consequences of disclosing. So I don't try to make that decision, but I at least try to help them along the way to do that. But it is a very difficult thing, and I recognize that.
Yeah, and I have a couple patients, like I said, I just educate them, and I have one who's struggling with telling their mom. And so I told them that they can bring them in, we can kind of go through it with her, because a lot of times with them explaining it at home, they don't really give all the details, and once they have the reaction, then they just forget everything. I actually have one patient who started back talking to their high school sweetheart and wanted me to take over it with her. And so they went over very well. And when they come out, I just kind of give them, we have like basic pamphlets that gives basic information. I give them that to start with, and I say, hey, if they have any other questions, just call me. Or hey, if they want to come in with your next visit, we'll do your visit just like you're a brand new patient. So I'm talking to them and you at the same time, and they understand. And so that's been real helpful.
So partner education is what I hear both of you saying is an option for someone who's having challenges around sharing and disclosing, whatever it may be that there's a lack of. Steve, did you have any other questions from our audience?
We do have one.
Okay.
And that is, how do you handle patients, or how do you manage patients who may be interested in beginning PrEP, but because of the adherence requirements, as clinician, it's your understanding that they may not be emotionally ready?
It takes a lot of education, a lot of hand-holding, a lot of talking. But Jay does that really well in that part.
I really haven't encountered that so much. But and then like with the adherence part, I kind of go into, just like when I do with my HIV patients, I go into the reasons why we test so often. We go into the information about resistance, if they were able to convert. So I kind of just pretty much just provide them with the bigger picture and kind of go from there. But I really haven't encountered a whole lot of issues as far as adherence. They may miss a dose or two here, and I kind of say, hey, we got to get it together. We can't do that. But as far as just somebody just missing like several doses and having to constantly start over, I haven't really ran into that just yet.
And in the relationship, I would suspect it's important for your patients to be honest with you about what they have or have not done, particularly because oftentimes tests tell on us, right?
That's right.
We can tell you we've been taking medicine for 30 days, but when you see the results of those tests, they'll say differently, right? So it's always important for us to be honest, right? I will speak from personal experience. You know, it's always easier for me now to talk to my provider when I'm in the office, because she know everything. She know it all. So I don't feel an apprehension to ask really personal questions if I need to, because at this point, nothing's off the table. And I think, unfortunately, we are all at that place where we can open up to our providers, but we would hope that through this conversation and in conversations like you all are saying that you're having with your clients, that people will be more encouraged to raise questions and to always go prepared with, if not three, at least one question that they want to have their provider answer for them around how things are working. Because you know, we can be intimidated by y'all. Y'all wear those white coats. Y'all come in with those pads, and y'all are ready to go to business. When sometimes just saying, how are you today, could make the difference in that visit, right?
Right.
And so we hope that in the conversation today that our viewers and that hopefully some people who had a question about PrEP have had their questions answered. Are there any more questions from our audience, Steve?
There's one more.
Okay.
And this question is, are there clinical PrEP services available outside of the standard HIV STD clinics?
So I think the question is maybe in just regular family practice, maybe, if there are options for somebody to go and get PrEP services. Jay, you probably...
I think this person might be concerned, again, about stigma.
About stigma, yeah, so they don't want to go to a box HIV treatment facility. Are there other facilities that they could reach out to?
There are some, not a whole lot, but there are some. I will have to get that information, get it back to you. But we do a lot of our telemedicine with our PrEP patients. And right now, one of them is actually in, yes, it's actually in Bond Hospital. Right?
Okay.
So when they come in, nobody knows. They just know they're going to the hospital.
So you raise satellite health or telehealth.
Yeah.
So tell me about that. What is telehealth, Dr. O? I'm going to ask you what it is, and then I will speak to you, Jay, about how, if I'm a person like Steve has described from their online person, that the church ain't going to see me go see Dr. O, but if I can go see Dr. O otherwise, how can I do that? So what's telehealth first, Dr. O, and then Jay, if you would follow up with that, how I access telehealth medicine with MAO.
Let me just add to the answer on that. Hopefully through our education, there will be more PrEP providers available, and that it can be done straight through somebody's office. All right, so telehealth is where we're sitting in one room, and Selma or one of the other satellites has a receiving television, as well as a stethoscope with me and a stethoscope with them, so that we can see our patients, we can examine, at least a limited exam. There's a nurse on that end, and it allows people not to have to come all the way to Montgomery, or even they can go to another county. So we have 10, I think, at this point, telehealth. Is that right?
For PrEP or just come out?
No, just in general.
In general, telehealth in Alabama. And we've had the one in Selma is our oldest one. We have about 150, 160 patients, probably a little more than that, actually. But they are very pleased with that. We still see them once a year in person, and if needed, more often than that. But for a lot of people, transportation is an issue, getting to their closest physician. And just like you said, most of these satellite areas are not in some place that's an HIV clinic. It may be an ADPH, it may be the hospital, it may be something else that you can be going there for any number of reasons. So it's a lot of our clients are quite pleased with the telehealth.
And we talked about innovation earlier, so I think now we're starting to get to real solutions on how to be innovative and reaching clients where they may be and still delivering the care that they need, right?
That's right. That's exactly right.
Jay, how can, if I'm a person that's interested in such care as part of your satellite system, how then would I access that care versus coming to the clinic?
The original setup, you would have to come to the Montgomery office just to get it set up.
Okay.
However, right now we have a telemed clinic in Dothan. We have one in Selma that we're pretty much getting started. And then we also have a fairly new office in Atmore.
Okay.
We haven't started seeing patients there yet, but we will be starting fairly soon. But once you would call, and to set up your original appointment, you would call the Montgomery office. But say if you're in the Atmore, you would go there for your orientation. In Selma, you would go there. And then Dothan, you would go there.
Wonderful.
If you're here in Montgomery, we really don't do the telemedicine because you're right there in the office.
Right.
But for the other ones, you would just go into that particular office. You would start out with calling our main number, and then we would let you know which one we had that was closest to you.
That was closest to you, okay.
And then we get you set up and kind of go from there.
But then we do have people who go from Montgomery to a satellite clinic for that very reason,
Yes.
who don't want to be seen in Montgomery. So I think Aineville is the closest one, but they can go to, but all they need to do is call that same number Jay has put out there to find out all the different areas they could go, and they don't have to live in the area where that satellite clinic is. They just want to access care there.
And Jay, if you would, give everybody the main number.
The main number to contact us here at MAO would be 334-280-3349. And that's 334-280-3349. And that should go to our main desk so they can get you if you need HIV testing, if you want to get with our wellness center. That will get you in the door, and she will direct you to the place that you need to go.
Wonderful. Steve, are there any other questions from our audience?
There's one directed
And I think this will be our last one.
directed to Dr. O, and then to the panel.
Okay.
But Dr. O, do you make house calls, and that was in quote, to provide PrEP information to an HIV-positive patient's partner? Or if not, are there other programs or processes that you know of who would?
I do not make house calls. However, I used to. I really did. That's interesting. But I think if you call that number and you just really need to talk to us, I think we can make that happen. Now, you know, I have to do my safety thing, so I'm not going to go everywhere. But I think we are so excited about getting the information to whomever we need to get it to, that we can figure out a way if you call that number.
And equally, I would say to that individual that if they are not in the Montgomery area, they could certainly link up with us at Start Talking Alabama by going to one of our sites, either on YouTube, Instagram, Facebook, or Twitter. If they want to send us a direct message or a messenger message on Facebook, then we would be able to link them with resources that they need. And then in addition to that, they could also visit our website at alabamapublichealth.gov/Start Talking Alabama. I want to take the opportunity to thank each of you for such a spirited conversation today. I have walked away, even though I've been in this field for a while, I've walked away with some inspiration as well as some education from all of you being here, and I'm sure that our panel has done the same. And I want to offer you all the opportunity to say something closing, and then I'm going to close out our show.
I hope we all got something from it, those of us sitting here and those of you sitting out there. And I hope we're all inspired to go out and tell somebody else.
Same here. The first step is just knowing, and we do everything at ML that we can to assist you with that, as well as prevention, treatment. We do it all, so just call that number, and we can definitely help.
Absolutely. Have the conversation. Have the conversation. Speak to your peers about these things, and it makes it more comfortable. I encourage all the viewers to follow the campaign, Start Talking AL. Again, I'm Jonathan, the co-host on the campaign. So if you find me on social media, feel free to reach out to me. I'll respond to your message. And with me being in this position, I'm more than willing to assist anyone with whatever services you may need. So, yeah.
And again, thank you all for being here today. I want to thank each and every one of you for watching our show today, and encourage each of you to start talking. The conversation has begun here, but it continues offline on Instagram, YouTube, Facebook, and Twitter. You can follow us #StartTalkingAL, and we look forward to sharing space with you in the future. Thank you, and have a great, wonderful day.